Salam, and hello there. Today I'm going to explain salivary gland diseases. There are many classifications for salivary glands diseases. There are mainly seven. One developmental, two cystic, three inflammatory, four immunologic, five metabolic, six obstruction, and seven functional disorders. So these are classification of salivary gland diseases. I will go to every group. I will explain every type. The last one, functional disorder, I will explain it in another video. So, at first we have the neoplastic, not the neoplastic disease. We have at first the developmental condition. The developmental condition means that there is something abnormal during the development. So there are two types. We have the salivary gland aplasia, and we have the ectopic aberrant salivary gland tissue. So what is the difference between them? Basically, the difference between them is that the salivary gland aplasia means there is a missing of the salivary gland, and the ectopic aberrant salivary gland tissue means that we have a normal tissue, normal salivary gland, but in an abnormal position. So the salivary gland aplasia, to define it, we have a congenital absence of major salivary glands. If we have a parotid gland agenesis, it is sometimes associated with hemifacial microstomia. We can see it as a clinical appearance. So the clinical presentation of a missing salivary gland is, of course, xerostomia, mucositis, glossitis, and caries. The diagnostic approaches is we do the cyalometry. That means we measure the flow rate of the saliva, and scintigraphy. Then we do an X-ray of it. So the second one is the ectopic one. That means the most common type of the ectopic salivary gland is the stiffness latent bone cyst. If you see an X-ray, you mostly see like here is the mandible, here like radiolucent area. This is like the ectopic area of the salivary gland. And it's discovered actually like by routine X-ray. And the clinical presentation is we have no signs and symptoms. This is actually really good. And radiograph, as I explained, it's a small circular corticated radiolucent below the mandibular canal. The treatment is we don't treat, we just follow up. Okay, so these are the two types. First, of the developmental condition. Now we have the cystic condition. The cystic condition, we basically talk here about three types: the mucocele, the ranula, and the true cystic lesions. Okay, and the mucocele is a pseudocyst. What does a pseudocyst means? This is one of my videos. You can watch one of my videos to understand what pseudocyst is. It is a swelling. It is caused by accumulation of saliva at the site of a traumatized minor salivary gland duct. So this is asked. This can be asked by the doctors if it is traumatized by a major or if it is traumatized of a major or of a minor salivary gland. Just mainly here is minor, not a major. To the majors, we have the parotid and the submandibular gland. So if these salivary glands, these minor salivary glands are traumatized, okay, you see here is swelling. Okay, and we have two types of the mucocele. We have the extravasation mucocele and we have the retention mucocele. The extravasation mucocele means that the saliva accumulates into the surrounding soft tissue. Okay, and the retention mucosal means that the saliva accumulates inside the duct. So we have here that leads to cyalolith, that means salivary gland stone. Just to have an imagination about it, we have here like the outside, here the duct to produce the saliva, and then the saliva here accumulates here outside into the soft tissues. Here, the saliva remains in the duct, so it produces salivary gland stones. Second, we have the ranula. The ranula means also accumulation of saliva, but this is beneath the thin mucous membrane of the floor of the mouth due to sublingual gland ducts, due to the obliteration of the sublingual gland duct. We here talk about the minors, okay? Here we talk about especially about the sublingual gland duct. So we have two types. We have the oral ranula and we have the plunging ranula. The oral ranula means we have a leakage of the secretions of a major salivary gland above the mylohyoid muscle. So you see it orally. Okay, if you see like a swelling in the mylohyoid muscle area, this is like mainly the oral ranula. But if you see a swelling outside the neck here, then, okay, here, then it is called the plunging ranula. This plunging ranula is, mucus is collected along the facial planes of the neck. This is called so, but it's present in the upper neck. So if you have two types. You have the oral ranula, which is accumulated here, and you have the plunging ranula, which is accumulated in the upper neck, which is seen extra orally. Okay, so the treatment. What is the treatment of ranula actually in general? We do marsupialization and simple removal of the cyst. Marsupialization means if you open the cyst and remove it completely, and simple removal of the cyst leads to recurrence of mucocele 30%. So there's a recurrence, possibility of recurrence of mucocele 30%. That means that if we remove this kind of cyst, a mucocele can recur. So what is mucocele actually? Mucocele it's an accumulation in the area of minor salivary glands, but due to trauma. So then we do the excision of gland. This is one of the treatment. Or in recurrent cases, you do CO2 laser to ablate the surgical bed. So in both three cases, you remove this is the ranula. So then we have the third type. We have here the true cystic lesions. These are mainly parotid glands. We talked about mucocele, ranula, and now true cystic lesions. Mucocele, it is trauma due to minor salivary glands. And then we have ranula due to obliteration of sublingual gland duct. And now here with the true cystic lesions, we talk here mainly about the parotid gland, one of the major salivary glands. So we have here four types. We have the lymphoepithelial cysts. We have the hereditary polycystic disease. We have the parotid duct cyst, and we have the retention cyst. These four types of cysts, you could hear it, or you might write it in the books, just to basically, in general, to explain what the lymphoepithelial cysts are. These are solitary masses within the parotid gland. And why? What's the cause? It is due to inflammation. The treatment is we do superficial parotidectomy with preservation of the facial nerve. So the facial nerve is really, really important because the facial nerve is inside the parotid gland. So if you do any parotidectomy, any removal, any cutting, just be careful of the facial nerve. Okay, we talked about like the three types of the cystic conditions. Now we talk about the third type. This is the inflammatory reactive condition. Till now, we talked about the cystic condition and the developmental condition. Now we talk about the inflammatory reactive condition. The inflammatory reactive condition, basically, in general, we divide it into the bacterial group and into the viral group, okay? The bacterial group has two groups, has two types, the non-specific and the specific inflammatory type. And the second one is here, the viral one, and the viral can be classified into mumps, which you might hear it, of course, and Coxsackie A. The bacterial one, we have two types, the non-specific and the specific. And the non-specific, we have two types, the acute and the chronic. The acute, we have pain. The chronic, we have dull pain. The specific types are the tuberculosis, actinomycosis, and sarcoidosis. These are the three types. So now we talk about first the non-specific type. The first, the acute suppurative Cyalotinitis. So there are different terms in the topic of salivary gland diseases, Cyalotinitis, Cyalometry, and many terms. I've written them. I may post them because there are many terms which are similar but have different meanings. So acute suppurative Cyalotinitis. Acute suppurative Cyalotinitis is more common in parotid. Why? Because parotid gland has serous secretions. And these serous secretions, they lack the protective constituents immunoglobulin A and lysosomes, which are seen in the mucinous secretions. So the submandibular glands, which are mucin in saliva, they have potent antimicrobial activity. So that's why we see it mainly in the parotid gland than in the other type of glands. So what are the risk factors for Cyalotinitis? It is here the acute type where you have pain and swelling and suppurative secretions. So the risk factors for getting Cyalotinitis is poor oral hygiene. Okay, if you have retrograde contamination by oral flora, that means the duct of the parotid gland is in the upper second molar, and due to food press or something can go into the duct and cause Cyalotinitis and cause a retrograde contamination. Salivary stasis. This can be a risk factor for getting the acute type. Postoperative Cyalotinitis. The postoperative Cyalotinitis is the risk factors of postoperative Cyalotinitis. I don't know if I might do a video about it. The fifth one is the Cyaloctasis. The Cyaloctasis is if we have salivary duct dilation and calculi and duct stricture. So, of course, calculi duct stricture can cause Cyalotinitis. Cyaloctasis, salivary and duct dilation. This can be a cause too of risk factor. And the next one is the clinical presentation. What are the clinical presentations? With at first, general symptoms, fever. Then we have sudden onset of unilateral, bilateral salivary gland enlargement, overlying skin erythematous. Rarely we have cutaneous fasciitis. Rarely. So these are general symptoms. We have fever, enlargement. We have erythematous. So yeah. Then the treatment. The treatment is we do culture and sensitivity testing. So the second type is when you do supportive measures, which is conservative. You do fluid. You give fluid replacement, empirical antibiotic and analgesics. You have to improve the oral hygiene. The patient has to improve it. You massage the gland. You give warm compresses on the gland. and Saligox means saliva substitutes. So these are all like conservative measures, treatments, and if you if like the parotid gland fails to respond, you do the incision and drainage as a surgery. So then the complications is if you have a direct extension, because the parotid gland is close to the external auditory canal and the TMJ, and it can go even to the paropharyngeal space and lead to airway obstruction. Can lead to hematogenous spread. It can lead to dysfunction of one or more branches of the facial nerve. So it's quite complicated if you have an acute suppurative cellulitis, if you have an inflamed parotid gland. Just never forget, we have here the facial nerve inside the gland, which can lead to dysfunction of like many branches. And yeah, so the second type is the chronic Cyalotinitis. It's a chronic type, which means dull pain. And dull pain, it is mainly submandibular, not parotid gland. The pathogenesis is the bacteria which are involved here is the Streptococcus viridans, E. coli, Proteus, and pneumococci. Here viridans is really important. It's not mutants or something. It is viridans. So then we have the etiology is what are the reasons? We have ductal obstruction, same as the acute type. We have the secondary, just a secondary to acute parotitis. We have also retrograde infection associated with Jorgen's syndrome. Jorgen's syndrome is one of my videos. You can watch it and explain what actually Jorgen's syndrome is. So yeah. Then the clinical picture is you have a unilateral or bilateral swelling of the gland during mealtime. Is really important during mealtime, and it is we have intermittent remissions and exacerbations, so it goes and comes again, and we have mild pain and fever. The conservative treatment is you massage the gland, you give saliva substitute, Cyalotinitis, and if the conservative treatment fails, you remove the gland. And any chronic infection, this is really important, is liable to recurrence. So this is really important. This can be actually asked in the exam. So what swells or what gland can swell during mealtime? This would be the submandibular gland. Yeah. So now we have the third type of the inflammatory condition type. We have here the necrotizing Xylometaplasia. So what is necrotizing Xylometaplasia? It originates from minor salivary glands. So the questions, where did you hear the word minor salivary glands? Was in the area of the topic mucocele from the cystic condition, where the minor salivary glands are traumatized, which leads to accumulation of saliva. Here we have an inflammatory condition of the minor salivary glands, of the heart palate, of the buccal mucosa, of the lip, or of the retromolar area. The clinical pictures. Is presents as an ulcer and it is painless. Okay. The treatment is to self-limiting 6 to 8 weeks. So no treatment, no medicaments. The etiology is we have local ischemia, and due to trauma, local anesthesia injury, or smoking. So necrotizing Xylometaplasia is mainly of the minor salivary glands of the heart palate, buccal mucosa, lip, retromolar area. But you can imagine it really good on the heart palate, which are presented as ulcers. So the fourth type is radiation-induced cyalotinitis, and the radiation-induced is the patient gets high doses, which results in inflammation and permanent salivary gland damage, okay, and due to irradiation, it leads to, this is really important to memorize, hypoxia, hypocellularity, and hypovascularity. And so radiation-induced can lead to many diseases. So now we go to the second group. We talked now about the bacterial type, the non-specific, and the specific type, are just three types. I just name the terms: tuberculosis, actinomycosis, and sarcoidosis. Now the second type is we have the viral inflammation. We have here the mumps. The mumps is the virus which causes this mumps is mumps paramyxovirus. It's a contagious disease, so you can get it. So affects mostly children at 6 to 8 years. The incubation period to start the disease is 2 to 3 weeks. The clinical pictures, you mainly see like here a child, and you see like swollen cheeks, and this might be mumps. And the clinical pictures is that we have non-suppurative secretions. At first one gland is affected, then the other one, then it leads to looking at bilateral lesion, bilateral inflammation. The time is 2 weeks. 2 weeks, and the symptoms subside in 3 till 7 days. The recovery is 2 to 3 weeks. So the incubation time is 2 to 3 plus the 2 weeks. So about like 4, 5, 6 weeks, the child is affected. For any laboratory investigations, you see an increase in serum amylase. The complications of mumps is other organs might be affected: testes, ovaries, breasts, pancreas, and in adults, orchitis may lead to sterility. So just quite okay. So the treatment is what is the treatment? The treatment resolves spontaneously in 5 till 10 days, and for a symptomatic relief of pain and fever, you give analgesics and antipyretic. And for prevention of dehydration, you increase the fluid uptake. And mostly, most importantly thing is the bed rest and fluid uptake. So now we talk about the fourth type, the immunologic disorder. We have talked till now about the developmental condition. We talked about the cystic condition. We talked about the inflammatory condition, about the bacterial group, the viral group. The bacterial group has specific and non-specific types. Now we have the fourth type. It is the immunologic disorder. The immunologic disorder I've explained in another video, which is Jorgen's syndrome. Just to define it quickly, it is an autoimmune disease characterized by decreased lacrimal and salivary gland secretions. Now we have the fifth type. We have the non-inflammatory disorder. It's also called cyalotinosis metabolic. So usually the parotid gland is affected. This is the same as we have talked about the acute suppurative cellulitis, which is caused by parotid gland, and the chronic is mainly affected by the submandibular gland. So now we talk about the fifth type, the non-inflammatory disorder. There are like 4 types of metabolic non-inflammatory disorders. We have the metabolic endocrine cyalotinosis. It doesn't end with itis because it is not an inflammation. Example, diabetes mellitus. Nutritional type of non-inflammatory disorder, it can be starvation, malnutrition, alcohol cirrhosis, example history of alcoholic related cirrhosis, and drug-induced, if you give take anticholinergics, antidepressants, antihistamines, which can lead to a non-inflammatory disorder. Antihistamines can be taken if you have any cold or any flu. This can lead to xerostomia, generalized swelling. Why does it lead to generalized swelling? This can be just to understand it. It is due to cell multiplication, to increase the saliva, and if you have a long-term drug-induced treatment, it can lead to a generalized swelling of the gland. The sixth type is the obstructive disorder. This we have here cyalolithiasis, and cyalolithiasis is if calcific mass stones are formed within the ductal system of any major or minor salivary gland. And gout is the only systemic disease known to cause salivary calculi. And these are composed of uric acid. So now what we have here is clinical features. It is caused more, men are 2 times more affected than women. The submandibular gland is the most common type, which is affected 80%, part to 19%. Due to the mucus content, we have more viscous secretions. We have more serous secretions. The duct of the submandibular gland is longer and runs against gravity, and that means that the saliva can stuck inside the duct, and the submandibular duct is situated at lower level than its orifice, so there's a higher possibility to get cyalolithiasis. The signs and symptoms. We have actual absence of subjective symptoms. The eating initiates intermittent transient swelling accompanied by moderate discomfort. We have mentioned this, something similar during mealtime. This was also due to of the submandibular gland. This was the chronic Cellulitis, which leads to swelling unilaterally or bilaterally during mealtime. So the submandibular gland, don't forget, it swells during mealtime. And so then the third type is we have no salivary flow or purulent discharge. And if it is not treated, we have swelling, redness, tenderness, skewed form of the duct orifice, and the intraglandular stones. This is really important, and this is a really important sentence. The intraglandular stones cause less severe symptoms than intraductal stones. So intraglandular inside the glands have less severe symptoms than inside the duct. What is the diagnosis? Diagnosis is if you have a history of swelling during mealtime, if you palpate any hard calcific stone, you do the occlusal view, or you do the CT, MRI, ultrasound. You see it in the ultrasound if the lesion is bigger than 2 millimeters. If it is less than 2 millimeters, you won't see it in the ultrasound, and you do sonography. So taking X-ray is the most important thing. But the history, if you have a history of swelling at mealtime, then it might be a lesion in the submandibular gland. Treatment is quite many. It is to have an effective treatment depends on the location of the stone and on its effect on the gland function. So we have at first the conservative management. The conservative management just to avoid like any surgery. It is better like a treatment type is to remove the stone by stimulation of saliva, through hydration, through application of moist warm heat, gland massage, use of sialogogues or milking the gland, or by manipulation. You open the duct with aid of lacrimal probes and dilators to retract the orifice. The stone can be grasped and removed. Okay, so this is no surgery. This is not a surgery. You do it like, yeah, with help of some instruments, but no surgery. You don't do like any cut inside the duct. So then you have the surgical treatment. Either you remove the stone or you remove the gland. This is called cyalodinectomy. Indication when do you remove the gland? If you have very posterior stones, if you have intraglandular stones, and as I've said, it's intraglandular stones have or cause less severe symptoms than intraductal stones, and irreversible parenchyma damage. So these are the three indications to remove the gland. Now we have a modern treatment. If you have any obstructions, you do the cyalolithotripsy. This is you use like a machine. It's not like a machine, but it's like a machine which has shock waves, and this fragments the salivary stones. And when you fragment the salivary stones, you flush them out throughout the salivary duct system. And the second type is the interventional cyaloendoscope. So these are the two types of the modern treatment. You use like shock waves, or you use the endoscope. And and if you have the second type is of obstructive disorder. It's not only cyalolithiasis, but the second type is the ductal stenosis. Ductal stenosis means what are the etiology? It is at first congenital. The reason is secondary to trauma or surgery, and or recurrent infection. You have swelling, pain at mealtime. You have recurrent infections. The diagnosis is cyalography, and the treatment is one of the modern treatments, cyaloendoscopy. You use like a cyalo balloon. You put it inside, and then you inflate. You inflate it inside the duct. So why do you do it? To dilate the duct. So this is the second type. The seventh type is the functional disorder. I think the video is now too long. I will explain it in another video. I hope you understood the types of the salivary gland disorders. If you have any questions, please write it down in the comment below. I'm glad to see any comments of you. Please don't forget to subscribe, and I will see you in the next video.